Welcome to BrainTalk, a podcast from Project BrainStorm about the bipolar spectrum. Your hosts are Dr. Jim Phelps, a psychiatrist and author of several groundbreaking books about bipolar, and Sara Schley, co-creator of BrainStorm the Film, a documentary inspired by her memoir, BrainStorm, From Broken to Blessed on the Bipolar Spectrum. Each episode of BrainTalk will interview new experts about their research and expertise within bipolar. Let's work together to save lives, end the stigma, and create healing for everyone on the bipolar spectrum and those who love them.
Hey there. Good morning, Jim.
Good morning, Sarah. Nice to see you as always.
Same here. Today we have a really interesting and special, wonderful guest. His name is Dr. Josh Rosenblat. He's out of Toronto, Canada, University of Toronto. And I was privileged to meet him last February, when we got to film him from BrainStorm the Film, focusing especially on his work in ketamine. We also filmed a young man who had been or still is one of Dr. Rosenblat's patients, Graham Fry, and Graham tears up and says, he saved my life. Ketamine saved my life. I found that really interesting.
So I know that you are very interested in this ketamine story, and I am as well. And with Dr. Rosenblat, there is an additional story. So Dr. Rosenblat has some serious training in psychopharmacology, more than is typical for a psychiatrist. And so I'm looking forward to asking him about insulin in particular, which he has studied because of its role in brain metabolism and in management of inflammation. So we know that those are two parts of the story about what causes bipolarity. There's more to this fellow than ketamine, let's put it that way.
Okay, well, that's good. It's a good thing you know all about that. I'm curious because I thought insulin just had to do with diabetes, but we're going to learn something today.
Yeah, we are going to learn something
Dr.
today.
Phelps and from Dr. Rosenblat. He's got that really lovely Canadian accent that I always feel makes them smarter than we are, and just nicer north of the border. Let's just go ahead and welcome Dr. Josh Rosenblat. Welcome to the show. Welcome to Brain Talk, Dr. Josh Rosenblat. We're so glad to have you here this afternoon.
Thanks so much for having me.
Thank you for coming. Sarah had introduced you to me as an expert on ketamine, which I gather is quite true. But I looked at your credentials and I see that you've been up to a good deal more than that. So we're excited to talk about numerous things in the realm of psychopharmacology and brain chemistry. Thank you very much for coming.
My pleasure. Great to be here.
And is it okay to refer to you as Josh?
Josh is perfect. Yeah.
Josh is good. Okay, Josh. Great. Well, I had the privilege of meeting you last year when we were up in Canada filming for BrainStorm the Film and focusing on your work in ketamine. So maybe you could just start, by letting us know how you got onto this path, including, being a psychiatrist, what got you interested in bipolar, and ultimately the treatments that you're using.
I really became very interested in mental health in general during medical school. It took me a bit by surprise where I was heading down a different path towards cardiology, and then meeting with patients with depression, bipolar disorder, it really engaged me. So that's where I switched paths. And since then, been focusing in on mood disorders, and my greatest passion is for bipolar disorder specifically. I find it the most interesting, so that's really what I've been dedicating my career to. So I see patients clinically, provide treatment, but also do a lot of research because I know that the outcomes are unacceptably poor right now, and we need better treatments for our patients. So been working hard at that to try to find better treatments for people as well.
I'm sitting here a little stunned because, mental health is not the most, it's not the flashiest specialty to consider for a medical student. But being a young man, perhaps the mood is changing there in medical school. Were you a loner in this, or were others following you as well?
Yeah, the tide was starting to change around my year. For my year, at least in Canada, this was the first year that all residency spots for psychiatry were filled in our province. So usually there was lots of open spots, meaning that programs want to train psychiatrists, but there's not enough medical students that are interested. But in my year, it was the first year that it was a good match of the number of people that were interested. There was that many spots. So now it's actually become a more competitive specialty in that there's more people that want to become psychiatrists than spots available. So the tide definitely has changed. More people are quite interested. I think going back to middle school and high school, we're talking about mental health more, so people are thinking about it more as an issue that requires support. So my sense is that things have really moved in a positive direction, where it's a quite popular area to go into right now.
Wow, that's great.
That's amazing. We get talented people like you
Yeah.
So what was it about bipolar disorder in particular? And by the way, on behalf of those who live with bipolar, I'm grateful for you and your work and your focus and your passion, like Dr. Phelps. What was it about bipolar disorder in particular that, has caught your passion?
I've always been very much drawn to complexity. And from
Mm.
my perspective, bipolar disorder is one of the most complex conditions in all of medicine. There's so much to think about from a pharmacology perspective, from a psychosocial perspective. And so that's what really drew me in, that thinking that, this is somewhere that having expertise and really thinking about a holistic approach can be quite helpful. And just this idea that we're not only trying to boost people's mood up, but we're also trying to prevent them from becoming manic. So I really enjoy that complexity. And then also because it's the land of what we call comorbidity, where people don't just have bipolar disorder, they have anxiety and ADHD and personality issues. And so all that complexity really drew me in, that, this was a fascinating area that I felt that I could spend the rest of my life treating people with bipolar disorder and never get bored. So that's what really drew me in.
Yep.
Wow.
Yeah, I would say, I would come home, and say, there's one thing about doing this work. It is never dull.
Mm-hmm. Yeah, absolutely. Never a boring day.
You could see Jim over there smiling and nodding as you're talking, Josh, going, "Oh, look at this is one of my tribe."
Yeah, absolutely.
Good. That's really good. And like you said, I think unacceptably poor current reality in terms of outcomes for people living with bipolar. What are you seeing there? What's the gap, and what are you hoping to see?
Yeah, so with currently available treatments, about 1/3 to 1/2 of people will do well on those treatments, depending on what study you read, which is great. It's very gratifying to prescribe a medication that's approved for bipolar disorder and someone does well, and then they go on their life being very happy and stable. But the reality is that, over half of the patients, unfortunately, don't have that story, and they're struggling with this difficult to treat course, just not getting better. So that's really what I've been seeing, where I have such an appreciation for the approved medications that are currently available, but also such an appreciation for these people that are coming to my office all the time, suffering and not getting better with the conventional treatments.
Mm-hmm.
And people who are coming to see you are likely to have not gotten better on several different tries of things. You're a secondary or tertiary or quaternary referral person. You wouldn't be seeing folks for their very first episode. Is that fair?
That's correct. That's correct. It certainly is possible, but on average, people have tried a dozen treatments before they see me. So it is a fairly select group of people that they feel like this is their last hope. And I'm often providing the counseling that there's actually lots of other options still available, but that's the population that I primarily work with.
Yeah, I'm familiar with the pressure that puts on you when you are it feels like court of last resort, right? Like, if you can't fix this, no one can. So, have a go.
Yeah, absolutely. That's exactly the feeling.
Well, I've got a window into some of the amazing results you're having with ketamine. And we met one of your patients, Graham Fry, who's on the film, and he said, quote, "Dr. Josh Rosenblat saved my life." Tell us a little bit about ketamine. It's controversial. It's in the news. There was a movie star recently who OD'd, but using it as a street drug, and so it's got a bad rap that way. Yet in the world of bipolar, people are starting to know about it more. And tell us about ketamine. How's it work?
Yeah, and I'll try to be brief because I could go on forever about ketamine. I'm just so passionate about
Yeah,
ketamine and bipolar disorder. So ketamine was initially developed actually as an anesthetic, so used to put people to sleep when they're having surgeries. But around 25 years ago, it was found that at low doses, sub-anesthetic doses, meaning not the full dose used to put people to sleep for surgery, it was found that people were a lot happier the next day. So the initial studies were not for depression. It was more so a model of schizophrenia and trying to do cognitive testing during ketamine infusion. But then they started to see this. So they studied it and they found, wow, there's amazing results where people that even have not responded to conventional treatments do really well and have these rapid benefits within an hour of treatment. They decided to study it more. So over the past 25 years, there's been a ton of research now. There's been over 50 clinical trials evaluating ketamine for depression. But with bipolar disorder specifically, that has very commonly been an exclusion criteria. out of fear. Are we going to make people manic? Are we going to make people psychotic? So they've been excluded from the majority of the trials. So I was very interested in testing it in this group carefully and cautiously. And so we started to do that work, and we saw some amazing results for people like Graham. And so we've published our initial, pilot findings, and now we're doing several large clinical trials to test this more definitively. But the initial results have been quite promising. It's a challenging balance for me where there is so much hype about ketamine and psilocybin, which are my two main areas of research. So of course I get caught up in it and excited, and I'm seeing patients sitting across from me in my office here saying that we saved their life with this treatment. And at the same time, I'm very careful where I don't want to suggest that conventional treatments are useless. Because I think that's the challenge, where I do see a lot of people also who might have not tried medications, and they say, well, I'm not interested in these useless medications. I just want psilocybin or ketamine. So that's something I'm always being careful as well to, give credit where it's due on the conventional treatments. But I can't stop being excited.
And I'm sure you also know from experience, hope is a double-edged sword, because it increases the chance that someone's going to get a good response. And yet if they don't, it can be dangerous and so disappointing if you've raised hopes too far. So also part of the balance before you begin.
That's
Absolutely.
interesting, you guys. On the other hand, I'll say from my standpoint, hope is like essential. So I'm personally really interested in ketamine, or the kinds of alternative treatments you're talking about, psilocybin, if they have that sort of almost miraculous effect in some cases without the bad side effects. Can you talk a little bit about the risk side? Are there side effects like that from ketamine?
So with ketamine, the majority of the side effects is during the actual infusion. So the infusion is 40 to 60 minutes, and there's both physical side effects and psychological side effects. On the psychological side, the most common thing would be dissociation, feeling like things are a bit different, a bit fuzzy, like things are moving a bit slower or maybe a bit faster, just a bit of a distortion of reality, not typically full hallucinations in terms of hearing things or seeing things that aren't there, but just this general sense that things aren't quite real and things are a bit off. Sometimes that can be a very positive experience, and other times it can be a bit scary. So we have certain mechanisms to help ground people during that experience to reduce the likelihood of a bad trip happening in terms of a negative experience. So that's on the psychological side. On the physical side, nausea and in worst cases vomiting would be relatively common. So sometimes we have to give anti-nausea medications, and then a temporary increase in your blood pressure by about 20 points that comes right back down afterwards. So those are the main side effects. Of course, there's a long list otherwise. The night of the infusion, some people sleep great, some people have vivid dreams and sleep very poorly. And then the next day, most people feel pretty good. Might have a bit of a mild headache or something like that, or feel a bit tired, but most people feel pretty good. And in fact, we're doing a lot of research right now to see if there's potentially pro-cognitive effects, that ketamine might actually be improving cognitive function. So I have 3 PhD students right now working, their entire thesis is on, each of them is dedicating 6 years of their life to look at the effects of ketamine and psilocybin on cognitive function. And one of them specifically in bipolar disorder with ketamine. So lots of hope there as well, that, when you look at something like ketamine that might improve cognitive function, that might be a nice alternative to ECT, electroconvulsive therapy, that's known to have, unfortunately, a negative impact on cognition, even though it's very effective.
Mm-hmm. How long do these the antidepressant effects last post an infusion?
We do an acute course, so 4 to 6 infusions, and after that acute course, that might last 1 week up to a couple months. So unfortunately, ketamine, from my perspective, is similar to other antidepressants and mood stabilizers, that when you stop the treatment, it's a matter of time for the symptoms to return. Certainly, I have lots of those cases where someone has 6 infusions and is well for years later. But for the large majority of people, I find they need to come in for further treatments, further booster infusions. And unfortunately, we haven't found a way to prolong the benefits of ketamine in the absence of more ketamine. So most people come in about once a month for a booster infusion.
Believe me, it's worth it. If it's
And any evidence of tolerance that as you go along, that's not working quite as well as it did at first?
The long-term data primarily is from S-ketamine nasal spray, Spravato. The 4-year data looked very positive, where people that responded initially were able to maintain their response for years after, when they kept coming in every couple weeks for booster S-ketamine treatments, with the exception that sometimes we have to increase the dose. So sometimes over time, people need a bit of a higher dose to get the same effect. But in general, large majority of people that benefited acutely were able to be maintained with sufficient booster infusions.
So, what are your theories about how it works
How ketamine works?
for bipolar depression? Yeah.
It targets specifically a receptor, the NMDA receptor, that's part of the glutamate system. But the way I think about it is more broadly that it modulates the entire glutamate system. So in the brain, glutamate is the neurotransmitter that turns neurons on. What happens in the depressed brain is that there are certain parts of the brain neural circuits that are overactive, that are driving thoughts of depression, driving thoughts of suicide, and other parts that are underactive, the parts that allow you to talk back to those negative thoughts, for example. So with ketamine, our understanding right now is it helps to turn down the volume of those depressive networks and turn up the volume of the networks that help to combat depression and also improve motivation, improve enjoyment, all of these things. So it's basically turning down the volume of one area and turning up the volume of another using this glutamate system in your brain.
That I'm just thinking of this friend of mine, and she says, I have this inner prosecutor all the time. So I decided I have to hire an inner defense attorney. And it sounds like that ketamine is kind of that inner defense attorney that can combat or turn up the good
Or
Great analogy.
Or just, can we just leave the courtroom for a while? Thank you. Have the judge call a recess. We just have to not be doing this for a while.
Yeah, absolutely. Both great analogies.
So interesting. Josh, I know there's some studies now on bipolar 2 and psilocybin. And they've had some pretty interesting positive results in small studies. What are you learning and what are you doing?
Yeah, so there was one study by Scott Aronson that looked at 15 people with bipolar 2 depression and gave one dose of psilocybin with accompanying psychotherapy. And it was fairly miraculous results. If you ever get a chance to talk to Scott Aronson, the way he talks about this is just, he was shocked as the principal investigator meeting with these 15 patients and seeing that they just had full remission and were doing so extremely well and no hints of treatment emergent mania or hypomania. So very exciting results in that first study. So we did the first RCT, randomized controlled trial, to include bipolar 2 disorder. We initially actually were going to include both bipolar 1 and bipolar 2, but Health Canada, our FDA equivalent, said, don't do bipolar 1. Start with bipolar 2. Show us safety in bipolar 2 first, and then you can try with bipolar 1. And I'm glad I slept better at night knowing that we had some risk mitigation there. So in our study, it was primarily unipolar depression, but we had 4 people with bipolar depression, and they did quite well with the psilocybin in our study as well. And now we're doing a lot more work in that area. So this month we started another trial with bipolar depression, bipolar 2 depression with psilocybin. My hypothesis is that for people with treatment-resistant bipolar depression, we actually need to turn up their emotions and turn up their amygdala, the emotion center of their brain, to allow them to heal. So bipolar disorder is always thought of as sort of an overactive amygdala, over-emotional, manic, depressive, sort of these, like, we need to turn down the volume on your emotions because it's too intense. But for people that have tried mood stabilizers where we've hammered down your amygdala and your emotions and you're just feeling numb and still depressed, for those patients, I'm hypothesizing that we need to turn up the volume, allow them to feel their emotions, have that catharsis, process it in psychotherapy, and then be able to heal from there. So psilocybin is the opposite of a mood stabilizer. It cranks up the amygdala and makes you feel very strong emotions. So that's what we're doing in this study, where we're giving people with bipolar 2 disorder, treatment-resistant bipolar 2 disorder, psilocybin. We're looking at their brain in an MRI machine, and we're seeing, is there an association between increased amygdala reactivity to emotional stimuli and benefits? Is this a good thing that we're turning up? So it's sort of trying to change the paradigm of how we think about bipolar disorder, using psilocybin not just as a treatment, but as a probe to test our theory, basically. So that's one study. And then we're doing a classic RCT, randomized control trial, to test efficacy in a sort of path towards getting this drug approved for bipolar depression. So that's more of a standard clinical trial that we're doing with about 100 people.
And in your randomized trial, you'll have a control group that's getting some kind of active treatment as a comparison group?
Correct. So both arms get quite a bit of psychotherapy, talk therapy, and one arm would get a high dose of psilocybin, and one arm would get a low dose of psilocybin or a placebo dose. But with the microdosing literature, who knows, maybe that's helpful as well.
Right.
So that's something that, in one of our depression trials, not bipolar trials, we're seeing some people with the microdose having some pretty amazing results, even though they have no psychedelic experience. So that's what we're doing for the control arm.
That reminds me of a fellow out in Seattle, Washington, who was studying seasonal affective disorder, and they were trying to test light boxes and dawn simulators. And he said, the problem is that people go out and get in the sunlight sometimes. And so the entire population is getting it's like someone's coming along and putting Prozac in the water supply. And when you're trying to study Prozac,
Yeah, great example.
So, Josh, one of the things, because I've talked to Dr. Tricia Supes out at Stanford, who was part of that study, I think, with Dr. Aronson, and she always mentions, be careful. This is not a street drug, not going to your next door neighbor who happens to have some psilocybin and doing it there, but rather, with psychotherapy in a controlled situation, because with bipolar brain, it could be dangerous to just do the alternative. Do you want to talk about precautions?
Absolutely. I feel that there is so much caution that's required. In Canada, there's been a massive increase in recreational psilocybin use. And I think part of that is being driven by people feeling like this is a safe and helpful thing for people to do to improve their mental health and their well-being. In general, not just bipolar disorder, I think we need to be very careful with these are very powerful substances, which is probably what makes them so effective. But at the same time, that could lead to some pretty negative results in terms of people being in a very dark place. There has been a bit of a signal for temporary suicidal thoughts that could emerge with psilocybin as well. So as you can imagine, if any of these bad things happen and you're not being supported by a team of experts, that could lead to a devastating outcome. So our protocols are very resource intensive. There's an 8-hour screening visit where we go through everything with the patient. There's preparation psychotherapy where you're meeting with a psychiatrist and a psychotherapist, and they're preparing you for the dosing session, setting intentions, and then you have the supported dosing session where you're here in the hospital for 6 hours and we're supporting you through that experience. And then there's integration sessions to help you revisit the experience and leverage it for making positive changes in your life. So without all of that surrounding it, I don't think it's particularly safe and maybe not an effective treatment. We are testing that now as well. Do you need the psychotherapy for it to be effective? But that's completely different from just doing it in your basement on your own, or even doing it in your basement with a friend.
Yeah, I'm thinking about here in Massachusetts, we had a referendum in November asking voters, should we legalize psilocybin? And I wasn't quite sure which way to vote, Dr. Rosenblat, having spoken to you, because of the risks and the rewards. I'm not sure I'll share which way I did end up voting, but it did not pass in Massachusetts. A lot of people were disappointed by that. What do you think? Should that have been? I'm not sure if you're aware of what the referendum was, how they phrased it or framed it.
Honestly, I don't know, because I think it's much more, it's about a lot more than the medicine. It's about philosophy, it's about ethics, it's about autonomy, all these things. So I could certainly speak to that. There's high risk to taking this on your own, but in terms of legalization and if people should be allowed to do this sort of above ground, I'm not sure. It's too complicated for me to really opine about, but it's such an important question that I think hopefully collaboratively we can bring together the ethicists and the politicians and the scientists and the researchers and patients and come up with an appropriate answer that is ethical and appropriate.
But if somebody is listening to this, is suffering, is tried many things, is wanting to get help, how would they do that, Dr. Rosenblat, whether in the States or Canada? Are there clinics that are accessible to them? Or
I'm a firm believer that the first starting point is with your primary care physician. I know there's maybe different names for that in different parts of the world. Here, they're called family doctors. Always good to engage in a conversation with them initially, where they could help to send you down the path, okay, maybe you need to start with talk therapy, maybe we should start a medication, maybe I should refer you to a psychiatrist or to a clinic that can provide you ketamine. So I think that's the starting point, starting with your family doctor, which is hopefully a person that you trust and you can open up with. Certainly there's lots of psychiatrists in Canada and in the States that can provide that general assessment, and then there is these specialized clinics too. There's the challenge of that you need to find a reputable one where it's a bit of the Wild West in certain. I think last I checked, there was 500 ketamine clinics in the States. So some of them use evidence-based protocols and some of them might not. So I think that's sort of an important question to ask in terms of, is your protocol based on research or is it based on your opinion and sort of what you've just been doing? So I think credibility in the space of ketamine clinics is really important to assess.
Oh, indeed. I think, it's like going to see any psychiatrist. How do you know, or any psychotherapist, really, or any physician, how do you know whether or not this person really knows what they're doing? Unfortunately, I think for many people, at least in the United States, there's not a whole lot of choice. A lot of people are really stuck with the one person that they can get to, and some people struggle to even find one. That's one of the reasons why I've been putting a lot of educational resources online, because I think, in my experience, what people do when they are struggling to find anyone who can help them is they start trying to teach themselves. Well, okay, so bipolar, maybe I have bipolar. What is this bipolar? Let me learn about bipolar. Let me learn more about the treatments. And so they become really highly educated, really quite often. And if we can facilitate that, we can prepare them to work collaboratively with a provider, so that they're not quite so dependent on what that provider knows. At least that's my, talk about living in an ideal world. That's my ideal, is that we have really well prepared patients who are able to engage in shared decision making through a patient education program that precedes making decisions about treatment.
And those of us who are, going to get armed with information, like let's say the folks on the Bipolar Social Club were sharing information all the time. And if you want to know about that, look up Bipolar Social Club and you can join this network if you live with bipolar. But let's say, so someone does want to try ketamine, then you're saying there are 500 clinics in the States and you'd have to do some kind of research and hopefully find one that's not too far from you.
I think it was long before you got interested in ketamine, you were studying insulin, or at least had a considerable exposure to the role of insulin in mood disorders. And I know that a team of your colleagues in Canada from Dalhousie have been looking at insulin resistance and its role in treatment-resistant bipolar depression. So I wondered if you have some thoughts about that, because in my mind, it's like, before we even get to other treatments, if there's this other problem, as you talk about the comorbidities that are so common in people with bipolar, maybe there's another way we can go about this without even having to look at bipolar treatments per se, or at least in conjunction with them. So, sorry, long preamble. So, hey, Josh, what do you think about insulin and the role of insulin in bipolar depression?
Fantastic question. I'm glad we were able to get to it. I'm going to steal a phrase from my colleague, Rodrigo Mansour. Sometimes we forget the brain has a body. And we're just so focused on targeting the brain with these neurotransmitters and psychotropics, and forgetting that there's this huge thing that's attached to the brain, and that there's a huge crosstalk with insulin pathways, with inflammation, with your gut, the gut-brain axis, all of these things. So I think just broadly understanding how medical comorbidity impacts the brain, and that is most typified in bipolar disorder. So going back many, many years, even Kreplin, one of the original people to characterize psychiatric illnesses, made this observation that people with manic depression, bipolar disorder, were short and stout, and people with schizophrenia, dementia precox, were tall and thin. Of course, that's not always the case, but there's this huge comorbidity, coexistence of another condition with bipolar disorder, where there's a huge prevalence of metabolic syndrome, central obesity, insulin resistance, diabetes, high blood pressure, all of these things. And it's not a coincidence. So there is a lot of these common pathways where we're learning that when insulin signaling in the brain is abnormal, that can lead to mood disorders as well. Insulin resistance is also associated with inflammation, and that leads to it as well. So huge crosstalk there for sure.
Yeah. And one of the reasons why I raise it is because we have been, I think, too complacent about giving medications that can cause insulin resistance.
Mm-hmm.
Studying ketamine is a way to not be involved. Is there a way to do this without having to cause that kind of additional risk in a condition that we know is already prone to that risk of weight gain and metabolic syndrome? So I'm thinking, well, if I was a young person like you, I would be doing something, studying a way to get away from these medications that can cause insulin resistance, like the sort of middle generation of so-called antipsychotics. I'm hoping that the newest generation of them is going to be doing that less, and it appears that that's true. But boy, that middle generation, which was the one that I was using a lot, I feel like, man, I was just contributing to the problem. It's one of the things that drove me into being so excited about lamotrigine and lithium. This is pre-ketamine, because these were tools that didn't cause metabolic syndrome.
Is that if they're insulin resistant, does that mean people develop diabetes? I just know insulin related to diabetes. Is that what? Yeah. Okay. That's the outcome.
Yeah.
And some certain drugs could cause that. And then therefore you'd have the comorbidities. Josh, it's been so wonderful to have you here this morning. Thank you so much for taking your time out of gratefully busy schedule that you have doing this research, treating patients, probably teaching. Anything else that you would like to share before we sign off for the day?
It's just my gratitude for having me, but more importantly for doing this work. Sarah, especially, I know we've had lots of discussions about this, and your advocacy for this group is just so tremendous. And physicians and scientists cannot move the needle without people like you, Sarah, and you, Jim. I think, just everyone coming together is so critical. So huge appreciation for you dedicating your time to this really important cause. Really appreciate it.
Wonderful. Thank you so much. Have a beautiful rest of your day.
You as well. Okay. Bye for now. Take care.
Oh, what fun.
Right, Jim? Did I tell you he was part of your tribe? Super nice, super smart, super humble, and doing amazing work.
Yeah, really nice guy.
Right. I found it really interesting that he was saying in the one case, like psilocybin would ramp up your amygdala and your emotional thing, whereas lithium and lamotrigine that I'm on would tamp it down. How does that work, do you think?
Yeah, I imagine that what Dr. Rosenblat would say is that, oh, I'm sorry, that these are just simplifications. It's so much more complicated than that. The thinking about ramping up and damping down is very general terms. What he's trying to describe is that the amygdala, which we usually think is like a problem, too much activity in the amygdala, we need to damp that down. That's not the whole story. That for some people, and I'm thinking about the depressions that you described where you were just not functional.
You need to ramp it up.
Yeah, you have to actually get some parts of the brain somehow to be doing something more. Yeah.
That would be more intuitive to me. Yeah. Like get something moving in there.
Oh man, that's not how we want to start. Why don't we say, here's this medication, and I hope that this has I know that this has got a good chance of helping things. We'll see. And if it works, then we'll continue it for a while until you get a chance to see what life is like when you're actually fully functional and feeling okay. And then we'll have a conversation about how long you want to continue this stuff.
Although you'd have to tear my lithium and lamotrigine out of my dead fingers probably, because the beauty of being healthy and stable and having a full life that those meds have given me, along with everything else we talk about in the show, getting up and starting the day skiing or whatever it is, the sport of the moment, physical, emotional, creative, and spiritual. But in addition to all of those, the medication has been absolutely essential for my health. Yes. And so the risk is too great for me to want to contemplate. We've talked about this. Yeah. And I did watch my mother, who when you're on these drugs, you feel completely normal, right? So I remember my mom in her 70s, and she had a new doctor, and she felt completely normal and said, "Can I get off my lithium?" He doesn't know. He said, "Sure." He was a primary care. And she immediately tanked, from a plane at going 50,000 feet straight down to planet Earth in a complete devastating breakdown that lasted for a long time. So anyway, it's right. whether or not we stay with these things. But if they're a blessing, in my case, I'm staying with it.
Yeah, being careful, no matter what it is, on the going up and on the coming off. It really is a time to be careful.
Okay, well, thanks, Dr. Rosenblat, for that. Though it's very hopeful to think about these other treatments that could really serve and without horrible side effects. So
amazing.
Yay!
Yeah.
See you soon, Jim.
Okay. Take care, Sarah. Bye now.
Okay.
Thank you for joining us on BrainTalk, your bipolar spectrum podcast. BrainTalk is a program of BrainStorm, a multi-platform project about the bipolar spectrum, which also includes Sara Schley's memoir and a full-length documentary. We aim to save lives, crush stigma, and maximize healing for all people living with bipolar and those who love them. For more information, bipolar resources, and podcast episodes, head to brainstormthefilm.com.